Hi everyone, I know an awful lot of people in the room today, and just in true fashion of what we're being promoted to from the HSE point of view, hello, my name is Susan. So you'll all be very familiar with this term at the moment. But what I'd like to say is just give you a little bit of background about myself. I am a nurse. I trained as a nurse back in the 80s in Dublin, and would have been very used to training with nuns and the medical model of care, and social prescribing was practically unheard of in those days. We would have been trained in Roper, Logan Tierney model of care, where what you had to actually do is you had to do everything for the patient. You never encouraged to do the patient anything for themselves. So it's very, very unusual that we're moving now and we're going full circle and we're handing a lot more power over to the patient today. So just to say a little bit about myself, I'm a nurse and I'm now a manager with the HSE, but like they say, once a nurse, always a nurse. So I'll stick with that one anyway. So I would have worked in the acute setting around discharge planning for quite a while, and I'm probably an unusual individual in that I would have spent a lot of years in the hospital, gone out to the community. When people usually go out to the community, they don't come back into the hospital, but I did. And not only did I come back in, but I went back out again. So I could be considered to be a traitor by all means, but I have to say I picked up an awful lot of tips along the way. So just from the day, I'm 5 years in primary care now as the primary care lead, and from the first day that I went in, within a week or two, I had a knock on my door, and it was actually Susan Scully. And Susan said to me, there's something you need to know, that there's a whole community out there that are waiting to gain access to primary care teams. And what I said to Susan was, well, the first thing you have to do is you have to allow me to set them up before I can give you access. And at that stage, we only had 2 primary care teams. So there was quite a lot of work had to be put into, and there's a lot of staff members here today that would have pulled with me. And it was a whole new concept, because in the hospital, we were used to doing multidisciplinary team meetings, and it was our bread and butter. And I always seemed to be sitting at the head of the table, chairing these meetings. And suddenly I went out to the community, and apart from individual case conferences in primary care, be it with TUSLA or other agencies involved, there was no such thing as discussing patients in a forum of 5 or 6 different people around the table and the GP. So I suppose what I'm going to do is talk through the last 5 years with you. I don't think we're ideal by any means in primary care, but we have a vision and we are going in the right direction. Sometimes it's 3 steps forward and 2 steps back, but we can cope with that because I am an optimist, and I do try to bring the positive people along with me and try and leave the negative people sitting there, but I go back and look for them, and if they want to come, they come, and if they don't, I don't waste my energy. I try to plough on regardless. So when I'm talking about primary care today, I've actually picked 4 themes. The first is primary care, I suppose, where are we now, which I'll talk a little bit about. The second is primary care in Ireland and the progression and the lack of progression that we've made in Waterford, and what plans we have for the future. The issues presented to primary care will be my third theme. And then lastly, I suppose, what social prescribing can add to the primary care teams, and I feel it has, and it will continue a lot. So I'll just move on. They're the 4 themes I'd like to talk about. So the HSE transformation programme, people who don't know a lot about primary care will probably be a bit shocked to see the date. It's actually 2001 since the transformation programme took place. And my role at that stage was called a Transformation Development Officer. So it was to bring about massive transformation in Ireland in relation to getting primary care teams to set up in the community. And it's just a shift towards prevention and self-care and the right balance between primary community daycare and inpatient care. There was equality and risk involved. We were trying to simplify pathways, and we were told it was efficient and better value for money. And anything that keeps a patient out of the acute setting is value for money, and we all know the cost of an acute bed per night can be up in the thousands compared to a patient being minded in their home. So primary care service mean all of the health or social care services that you can find in your community outside the hospital setting. And from previous speakers, you can see there that there is quite a lot out there. And even in my role as a community liaison nurse in the hospital, I started off with a small little notebook, putting in all the contacts of every time I made contact with somebody. And there's people here today that I'm still in contact with since 2001 that offered me help for patients to get them out of hospital. And eventually I ran out of a notebook and I had to go to a second and third. And when I was leaving the hospital, they said, please leave it behind you. And I said, no, you can photocopy it because I'm bringing it with me. And basically, that's the way I started my role. My liaison post was the very first in the country in the medical assessment unit and the emergency department. But it's there because of the name of the post, community liaison, that I picked up an awful lot of my links. And it was these simple networking with people that has enforced the primary care teams and will continue to do so in the future. So primary care, anyway, is the appropriate setting to meet 90 to 95% of patient need or of clients' needs. So I love this because this really reminds me of the way things were. And if you look, when I went out as a nurse into the community, the GP was at the centre of the care. And I suppose it is important to remember that the GP in the community is equivalent to the consultant in the hospital. And I like even the way with the Donegal model that you link everything back to the GP, because Gerard O'Neill is not here now, but when we were setting up counselling in primary care, one of the big things about it was no matter who the referrer on the team is to counselling in primary care, that the copy of the referral has to go to the GP. And that was as a result of the GP saying sometimes you're all out there in the community, you're doing things and we don't know about it. So if a GP had a problem with the patient, he would pick up the phone and he'd ring the public health nurse, ask her to go out and see. This is what was done prior to the primary care teams being set up. Then he might ring the physio, he'd send a referral form, he'd ring the OT, he might ring the speech and language therapist, whoever. But mainly the PHN, I'd say, was probably who the GP would be ringing mainly. But we provided a forum through setting up the teams. So what we did is we set up our primary care teams, and when we had these established, it took us 2 years to do them. We then put the patient at the centre out in the community with the GP, the PHN, the physio, OT, and all the other services around it. So the whole is greater than the sum of its parts. This is a very good quote, and I'd see the primary care teams as we're all in a boat together. And that's very significant because some genuinely are floating and others can tend to sink. And the reason I'm saying that is not all primary care teams are perfect. From the 13 teams that we'd have, I describe them like 13 families. They all go through different stages. They all get on well together. They all have friction with each other. It is a lot of people to be bringing together and trying to manage all the different relationships. But when things do change, I still try to remind the team at every time, it's the patient is at the centre and always has to be. So the team's aim is to provide accessible, integrated, quality primary care services that meet the need of the local population. So the core members of the primary care team are the GPs, the practice nurses, the public health nurses, physios, OTs, and we have admin support for all the teams as well. And they're grouped into 3 to 4 teams per network, and I'll show you graphs of that now. And currently there's 4 networks in Waterford, and any of you who are on the teams at the moment will know that this is changing. So just in relation to where are all these primary care teams based, are they virtual, are they actually together? Every GP is in his own practice there's just a few slight differences. We've got 3 primary care centres. We've got one in Lismore Park, where some of our staff are based. We've got one in Waterford Health Park, where the HSE lease some accommodation, and that's the Roquaven practice. And we've got one in Tramore Primary Care Centre as well. And as part of the programme for government in James Riley's day, he asked us all to submit and do work around needs for primary care centres. And as a result of this, Waterford has been very successful in that it has 2 primary care centres currently being built. One is on the grounds of St. Joshrin's and will be the biggest in the country out of the 10 projects currently undergoing. And the other one is in Dungarvan. And this is the Dungarvan Primary Care Centre, and it's currently being built for any of you who are living in that area. And that we're hoping to open that up in February of 2018, and hopefully Waterford City Primary Care Centre on the grounds of St. Joshrin's will be open in July of 2018. They're the planned dates. So this is Waterford City, County and West Waterford, and these are currently the 4 networks that we have in place. The plan is to put this into 2 networks instead of 4 networks, and that's all in line with the Healy report of 2015 in relation to the reorganisation and the restructure of the current CHO5 and all the current structures in the country. So this is just a list of the primary care teams and how we divided them. So within a 2-year period, we established 13 primary care teams, and you can see all the different teams when they were established. You can see the population. We're still going on the 2011 census. The Waterford, it is important to say that when we're talking about Waterford City and Waterford County, we're also talking about South Kilkenny, which includes Ferrybank, Piltown, Mullinavat. That is all within Waterford primary care area. And these are the teams that are set up, just to give you a flavour of where they are. And each of those teams have GPs, public health nurses, OT physio, speech and language, and network services. So primary care team is the first point of contact, and it should always be that way. In relation to link with community-based professionals, I suppose what I wanted to say about the day that Susan knocked on my door and said that would you possibly come down and meet the Waterford Area Partnership and the health networks. When I went in that day, I felt overwhelmed, I have to admit, and I was only in the post about 3 weeks at the time. And I was overwhelmed at the amount of work that is going on, and that even though I was liaison nurse in the community, my notebook probably only contained 10% of what Susan was telling me that day. And Susan handed me a folder, and I have to admit it was about 6 months before I got to read it with everything else going on. But I couldn't get over the amount of work that's been done in the community, and that nobody on the primary care teams knew anything about what resources were out there, were already running. And I just immediately said I put a plan in place. So some of the things I did was the community health networks. I went back to Waterford Area Partnership and asked them to align themselves with the teams. And as a result of that, we did have people from the community health networks coming out to talk to the primary care teams, and I invited them in as guest speakers. Now, when the workers came in first, it did feel alien to people who were trained, not so much myself, but like GPs and other healthcare professionals in the medical model of care that would have been used to just prescribing medically. And all of a sudden we were asking them, now you have a responsibility to socially look after the needs of this person. So it did take a little bit of time to ingrain in. And I feel even with the social prescribing as well, we have a forum, we have our 13 teams, we have access where you can come in and educate people on the teams. And I think it is very important to say that a GP on average has a 10 to 15 minute window with the person where they're prescribing a medication, referring on to consultants in the hospital. And it is very important that if they have, what I would be working on this model with Susan and with Emma and Derval in the future, is to look to make it as easy as possible for all primary care team members. And I really admire what Carmel said about the phone call, the like counselling and primary care, the referral back to the GP to say this person is involved, because we already have the forum set up where this can be done, in that we've monthly meetings, we have patients' consent to be discussed at that meeting, and we now have a feedback mechanism with our admin supports that we can actually document into the patient's plan of care that this patient has been referred for social prescribing. Now, we're doing it informally at the moment, and I suppose just to go further on to say, once the health networks were matched up to the teams, I kept hearing about Waterford Area Partnership, what they do. They're giving grants to these people, and I started wondering around governance and how can I bring these people in? I need to know that there's proper governance procedures. And that was one of the things that the GPs constantly said to me, Susan, you need to bring people into these teams and tell us about it, but we need to know that we're safe if we're referring them on. So part of my role then on the Waterford Area Partnership was that I felt, I got insight into what a lot of these people had service level agreements with the HSE anyway, and I needed to know that if I was making recommendations of who we would refer our patients onto, it had to be a safe environment. So as a result of that, we had St. Paul's, St. Bridget's, Sacred Heart Family Resource Centre, Ferrybank, various different networks coming into the primary care teams and letting them know. And I suppose, back to what Carmel said again, they probably will be slow to refer initially to programs. It could be a number of issues. It could be, do they trust me around governance issues? It could be, do we have time? Or when they go looking for the number in that 10-minute opportunity that the patient is sitting there with them, do I have time to look up the Waterford Area Sports Partnership? So as a result of that, every single primary care team meeting has a 10-minute slot where guests come in, and very regular guests to us. We used to have Avril McCullough, who was our primary care psychologist, and she did the stress control programs. That was one of the highest attenders in the southeast for any program. We see Peter Jones in the room over there, and Pauline. I don't know if Pauline is here today, but Waterford Area Sports Partnership have been fantastic to the primary care teams, and one of the big things has been the Men on the Move program. Just to go back to your query about men and not. And what's very funny, I was laughing actually when you were talking earlier, because when I was at stage, I think Peter had been out to about 6 of the primary care teams, and we came to number 7, and I saw a very disgruntled female member of staff sitting there with her arms folded and wasn't having any of the Man on the Move thing. And I said to her, are you okay? And she said, what's all this about men on the move? She said, what about women on the move? Are they doing anything? And I think, what was your response to that, Peter? You do. You actually said, well, women are good at motivating themselves and walking, and and that had to suffice at the time, because they felt we were nearly being biased towards men at this stage because we kept promoting the Men on the Move. So, we are linked in with an awful lot of programs like that, and I think it did provide a gateway for all team members to refer on. So, back again to the millions of primary care team contacts every year through dietetics, physiotherapy, smoking cessation, counselling. There's 14 million GP visits a year, and we need to make the most of these, and we need to make them count. So these are all the people the primary care teams link in with. We have clinical team meetings once a month. There's a key worker allocated, and the location is in various different. We go into the GP's surgery and we bring the team members to them, because often they will tell us that they don't have time to come out, which they don't. And it's important to say that every single one of these primary care team meetings, I should be like skinny, because they're all at lunchtime. So every single one of them, and the GPs genuinely give up their own time. They don't get paid to attend them. So it does show, you know what I mean, that they are willing. And you will see a lot of GPs when you go eating the biscuits, or like you said, when you go to see them, or their sandwich, they genuinely give up their time. So the chronic disease is coming in. It's on the increase, and we're very aware in primary care that we do need to put in for a lot more programs that will look after chronic disease management. And we are setting up a league in CHO5 to deal with this. So the issues presented to primary care are chronic disease, huge social problems. 70% of all our health outcomes are determined by social factors, and we need to start recognising this. And I would be the first to put my hand up and say we need to get away from medical models of care. Okay, so this is just single-person households. 2-person households are more common, followed by 1-person household, and it's just the way our profile is going. Loneliness is a huge issue amongst older people, and we do link into St. Bridget's Family Resource Centre for an awful lot. They do offer an awful lot to GPs and primary care team members. So I would consider myself a primary care optimist. And the reason I'm saying that is I have met huge obstacles along the way. I was told you won't set up 13 teams, and we did. And like I said, they're not all fully functioning. Some of them are absolutely excellent, and others are struggling to meet once a month. But I am an optimist, and I will say that whoever is there will bring along with us. And I think social prescribing from primary care, it adds meaning to medicine. That's the big piece that I like. I think we have to get away from the medical model of care, and it will promote well-being, and it is very empowering. So that's me for today anyway, and thanks for your time.